Very good morning to one and all. I am Dr. Lakshmi Srikhande, your host for today's webinar. This webinar, the theme is high risk pregnancy. We are having two topics on optimizing fetal outcome in Rh negative pregnancy, and another talk will be by Amay Purandre on DIC. Then it is followed by a case-based discussion on thyroid disorders in pregnancy. So without wasting much time, let us go towards our scientific program. First, I would like to invite my guest of honor, Dr. Usha Sharma. She is the National President of ISOPA. Session ये आगे क्यों नहीं जा रही मेरी slide? Madam is very humble, down to earth. She is currently the National President of ISOPA. Madam is working as Senior OBGYN at Patna, and she is also honorary consultant at Holy Red Cross Polyclinic Patna. She is advisor to Safe Motherhood Committee of POGS. She has presented many papers at FOXI, ISOPA, RCOG, contributed chapters, and she has got many publications to her credit. Madam, we need words of wisdom and blessings from you. Usha madam, unmute kariye.
Yes, can you hear me now?
Yes, madam.
Yes, ma'am.
Now, I thank you all and feel privileged to be invited today for this webinar by Vidarbha ISOPAB chapter, whose president is Dr. Lakshmi Srikhande. Now, the founder president for laying Dr. Sneha Bhuyar of such a dynamic and vibrant society, ISOPAB society, which Dr. Lakshmi Srikhande continues the legacy with added zeal and passion. I think she deserves a lot of credit for that.
Thank you.
Today's webinar, as we can see, there are three. I can see Milind. I must say something about Milind, who is the patron, past president of ISOPAB, and still he is very dynamic and willing to do anything for ISOPAB. Am I correct, Milind?
Yes, madam, and we are blessed to have him as our patron. He is always there to guide us.
The scientific program today, as Dr. Lakshmi Srikhande has already said, is on Rh negative pregnancy and DIC, which I dread. I don't know about all of you. If we have to face such complication in a patient, which is fortunately rare, but yes, we all need ourselves to update on current advancement in such a complicated situation. And the third is a panel discussion or a case-based discussion on thyroid disorders, which also needs updating. I think now I will not waste any more time, and happy learning to all the people who are joining in this webinar, and long live ISOPAB.
Thank you. Thank you so much, Usha madam, for gracing the occasion and giving your words of wisdom and blessings. Now, our guest of honor is Dr. Hiralal Konar. I think everyone knows you, sir. You are active in FOXI, ICOG since last so many years, and he is member of Oncology Committee of AOFOG, and currently he is the journal editor of ISOPAB. He was chairperson of ICOG. He is national editor of the journal. He was president of Bengal OBGY Society almost 12 years back. He is past vice president FOXI. And friends, as you all can see, his real books in his background. And I was really asking him, sir, is this real or virtual? And he has got 2 rooms full of the books and journals. So hats off to you for having your passion in the publications and academics. The floor is all yours, sir.
Thank you, madam. This is the same passion as you have to your patients. We have to look after our students' books and the patients also. So to start with, it is my great pleasure to take part in this CME of Vidarbha ISOPAB chapter. It's a great honor and pleasure, as Professor Madam President Usha Sharma has already mentioned. And it is a great occasion to see that the Vidarbha dynamic isoprop chapter is progressing, and all these office bearers, thanks a lot to all of them, Dr. Milind, Dr. Sneha Bhuar, Dr. Alka Mukherjee. Alka Mukherjee called me long before for his publication of article in our journal. So I believe you have got a good team to lead the isoprop chapter of Vidarbh chapter of isoprop to in this the front side of this national platform. And to talk about this topic, I have got a special interest to that of the high risk pregnancy. So to say that, physiological changes in the pregnancy is the normal one. And when there is enormous changes in all the systems, cardiovascular, respiratory, endocrine, metabolic, all the system during the course of pregnancy, starting from the first trimester, second trimester, and third trimester. Again, there is significant hemodynamic change in the during the course of labor, and it comes down again gradually over the period of prepubium 6 weeks. Now then, whenever there is a risk factor comes, meaning that a hazard in the course of pregnancy, that makes the course of pregnancy difficult, and that's the main difficult areas for all us that of the obstetricians to manage the issue. And risk factor of pregnancy adversely affects the pregnancy outcome in terms of maternal health, fetal health, or the both. And unfortunately, till today, there is no such gradation or quantifications of the severity of the risk. But what has been mathematically done, I believe the postgraduates are also there participating in this CME. When it is mathematically done, we qualify it or quantify it in terms of risk ratio or odd ratio or confidence interval. But whatever may be, that as a clinician, we are looking for that of this outcome of the pregnancy in terms of maternal and the fetal health. Now, I wrote an editorial in the Indian Journal of Indian Medical Association 2004 when I came back from England with the concept that we need a separate subspecialty in terms of high risk pregnancy or medical disorders in pregnancy. Lakshmi, you would be remembering I led 5 years Foxy in the medical disorders in pregnancy, and that time I spread all over the country that physicians must be interested in the obstetric problems, not that we can manage everything. Again, at the same time, we need to involve them. That means multidisciplinary team approach in the management of complications of pregnancy, either with the high risk pregnancy or whatever call it, medical disorders in pregnancy. Believe me or not, WHO has estimated that 20% of the maternal death to the extent of 20% is related to the high risk pregnancy, medical disorders in pregnancy. And significantly, it could be reduced if we make a team approach with our colleague of the physicians and with the obstetricians having our effort to manage the complications or anticipate the complications. So with this background, what I feel that of high risk pregnancy is a separate entity, and it need to be emphasized amongst our professions, amongst our colleagues, that we need to have a multidisciplinary team approach depending on the situations of involvement with the physicians and with the obstetricians. Now, coming back to your topic, I'm very much interested that the prenatal outcome of research pregnancy complicated with research isoimmunization, high risk pregnancy that Amia is going to talk about, the disseminated intravascular coagulation. It doesn't need to say that it is a nightmare. When we face these complications, it is a nightmare for all us the obstetricians and this the hematological department. The other topic that you have considered rightly, very common topic, thyroid disorders in pregnancy. And I could see the stalwarts like Professor S.P. Joshua, Tarini is there, and there are other things that of the Dr. Bharati, Dr. Sujata, there are many other experts are there in the topic, common topic, till there is controversy. What is subclinical, what is clinical, what is gestational, all these things we need to understand, and it is so common, probably I believe all of us, the obstetricians, need to have the basic understanding to manage these complications. Thank you organizing this great CME. I believe it will bring an immense impact to all of us, including that of the postgraduates and the newcomers, the practitioners in our profession. Thank you once again.
Thank you so much, sir. I know your passion for high-risk pregnancy and the amount of work you have done as a Foxy committee chairpersons of medical disorders in pregnancy. I have very fond memories of all the work you have done. Thank you so much for your pearls of wisdom and giving your blessings. So thank you so much. Now it's my pleasure to introduce our patron, always smiling, our own Dr. Milind Shah. He is always there to guide us. Friends, you can see his credentials. If I start reading his biodata, it will take me complete 1 hour. So without wasting much time, Milind, I invite you to address the audience. Milind? I will display your slide so that audience can read it. Milind, are you there with me? The next in line where I would like to acknowledge the presence is our founder president, Dr. Sneha Bhuyar, and currently she is doing wonderful work as the chairperson of Female Committee of FOXY. Proud of you, Sneha.
Yes.
Are you with me? Our dynamic secretary, Dr.
Friends,
Alka
it's indeed a
Mukherjee.
pleasure to be part of this particular webinar.
Yeah,
Is it audible now?
you are audible.
Okay. So, Lakshmi, thank you very much for this kind invitation. It's indeed a pleasure to see the content of this particular webinar and this is pregnancy.
Unmute karo, Milind. Unmute
I
yourself.
got muted it up here.
Yeah, you got muted.
Now it's audible?
Yeah, now you are audible.
Okay. So friends, thank you very much. Lakshmi, thanks a lot for this kind invitation. It's indeed pleasure to see the content of today's webinar, and I'm so happy to see all these experts are going to have a good deliberation on this topic. I'm very sure all that wonderful work the Vidarbha ISOPAP is doing is going to play a long way in coming years, and it will be benefit for all the clinicians and the students. I wish you all the best, Lakshmi, Sneha, and all other office bearers.
Thank you, Milind. Thank you so much for gracing the occasion. Sneha, are you with me? Sneha is our founder president. She will join us shortly. Dr. Alka Mukherjee is the dynamic secretary of Vidarbha ISOPAP. And because of our emergency case, she is not with us right now, but she will join us shortly. So now let us move to the first session, the first talk. The opening chairpersons are Dr. Beenal Shah and Dr. Anil Sakre. So I will introduce both the chairpersons and they can carry forward the session forward. Dr. Beenal Shah is FOXY representative from Vadodara. She is past president of her society. She is currently the president Menopause Society of Vadodara. Beenal, wow, you have won 4 gold medals. She is the Gujarat topper. And she has done her diploma from Germany in gynec endoscopy. She is a very great academician, has got lot of publications to her credit. So welcome, Beenal. The next chairperson is Dr. Anil Sakre. He is from Nanded. He has worked as assistant professor at GMC Nanded for 11 years. Anil, you look young. He is an undergraduate and postgraduate teacher and examiner, faculty. I know you have been invited to various national and international events as an invited faculty. And he has got an enormous 19 scientific publications in various national and international journals. And he has served African countries and operated hundreds of cases through the Rotary Medical Health Camps. I really like this social cause aspect very much. And he has experience of operating more than 4,000 NDVH cases. So welcome, Anil, and you all can take the session forward.
Thank you, ma'am.
Thank you so much, ma'am. Thank you for this privilege and welcome all. Welcome to this very enlightening session, and it really gives me great privilege to introduce Lakshmi Shrikande ma'am from our Orange City, Nagpur. Lakshmi ma'am is the founder, patron and president of ISOPAP Vidarbha chapter. She has won Bharat Excellence Award for Women's Health Activities, Mehru Hansotia Award as the Best Committee Award when she was a chairperson in the HIV/AIDS Committee. She has delivered many orations and lectures, and she has many publications to her credit. Madam is the chairperson designate of ICOG 2020, and she is also on the editorial board of our journal, Jogi. So Lakshmi ma'am is a very passionate person, beautiful inside out. And over to you, ma'am, for a very important topic, that is the fetal outcome in a Rh negative mother. Thank you, ma'am.
Thank you so much, Beenal, for able to make to attend this webinar as well, and for your kind words of introduction. Friends, my topic of deliberation today is how to optimize the fetal outcome in Rh negative pregnancies. So why we have to worry about the Rh negative pregnancies? Because in India, the incidence of Rh negative in our population is to the tune of 5%. So we all obstetricians are encountering daily Rh negative mothers in our antenatal clinic. Just to tell you the few important landmarks in the history of Rh isoimmunization, friend, the existence of Rh factor itself was discovered only in 1940. The Lilly's chart for optical density on spectrophotometry of amniotic fluid came into existence in 1963. The first direct intravascular transfusion was done by Charles in 1981. But what was the breakthrough in this field was the development of anti-D immunoglobulin by William Pollack in 1968. The widespread use of anti-D has led to decrease in overall incidence of immune hydrops. You can see in the year 1970, there were 82% cases of hydrops were immune hydrops, but in the year 2000, after the discovery of anti-D, this incidence decreased from 82% to 10%. So this is a miracle discovery which has come into our armamentarium. I am having my presentation into three main categories: the pathogenesis, management, and prophylaxis. So in a very simple words, what happens if a mother is Rh negative and the baby is Rh positive? As you all can see, the mother is having Rh negative blood cells and the fetus is having Rh positive cells, and you can see that placenta is acting as a barrier. These positive cells are not coming into contact with the maternal cells. But sometimes this breach occurs in the placental barrier, like in cases of abortion, ectopic pregnancy, antepartum hemorrhage. When you are doing invasive fetal procedures like chorion villus sampling, amniocentesis, external cephalic version, when there is any kind of abdominal trauma at the time of delivery, when you are doing manual removal of placenta, or there is an inadvertent transfusion of Rh positive blood. So once this barrier is breached, there is an exposure of fetal antigens to the maternal circulation and the mother starts developing antibodies. And this sensitization process, that is the production of IgG antibodies against fetal RBC, it takes time. And hence it does not usually affect the first pregnancy. Antibodies remain in maternal circulation throughout the life, and once the mother is sensitized, she remains sensitized forever. There is a 1% chance of getting sensitized in antenatal period, but at the time of delivery, 10 to 15% mothers, they get sensitized. And what is the amount of blood needed for this sensitization, friends? It is 1/4 ml. That is 0.25 ml of fetal blood is sufficient to lead to alloimmunization and cause the sensitization and can lead to indirect Coombs test positive. So what happens in future pregnancies if the mother is sensitized in the first pregnancy? The antibodies are already present in the maternal circulation, and when there is a breach, these antibodies, they cross the placental barrier, they enter the fetal circulation, and they start causing hemolysis in the fetus, and this is the dreaded complication which we all are worried, that is the hemolytic disease of fetus and newborn. During antenatal period, this hemolysis can cause fetal anemia, hydrops fetalis, and fetal death. In the neonatal period, this can lead to neonatal jaundice, kernicterus cerebral palsy, and can also lead to neonatal death. So how to correlate this pathophysiology with our ultrasound findings? So the pathophysiology tells you that isoimmunized subsequent pregnancy, there is crossing of IgG antibodies to fetus via placenta. Antibodies, they attack the Rh positive fetal RBCs There is fetal hemolysis and there is fetal anemia. This fetal hemolysis and fetal anemia reflects in your ultrasound findings in the form of increased cardiac output, increased cerebral arterial flow, there is extramedullary hematopoiesis, and the end result is hydrops fetalis. So you can see the ultrasound signs of fetal anemia in the form of hyperdynamic circulation, which leads to increased flow velocity. The portal vein diameter is more than 5 millimeter. Because of increased cardiac output, there is cardiomegaly. CT ratio is more than 50%. There is right atrial enlargement, tricuspid regurgitation, and pericardial effusion. Because of hyperdynamic circulation, there will be placentomegaly, which is seen as a ground glass appearance of placenta on ultrasound. Polyhydramnios will be there. And because of extramedullary hematopoiesis, you will see the hepatosplenomegaly on the ultrasound. Hydrops is the pathological accumulation of excessive fluid within two or more fetal compartments. You can see the scalp edema or body wall edema, ascites, pleural effusion, pericardial effusion, polyhydramnios, and placental thickening. So because of high output cardiac failure, this is the end stage sign of fetal anemia, and usually hydrops is visible when the fetal hemoglobin drops to less than 5 gram%. So by preventing hydrops, we all can improve the outcome of these Rh negative pregnancies. Friends, in the field of Rh isoimmunization, apart from NTD, the second breakthrough which came into our clinical armamentarium is the use of middle cerebral artery peak systolic velocity as the non-invasive method to detect the fetal anemia. It was discovered by Mary et al. In 1995. And this is the most important practice-changing discovery. You can start evaluating MCA PCV from 18 weeks onward, but it becomes less reliable after the 35 weeks of gestation. So this is a fantastic way of non-invasive monitoring of these Rh negative pregnancies. It has a sensitivity of almost 100%, but it does have a 12% false positive rate. And MCA PSV has safely replaced invasive testing in management of Rh isoimmunized pregnancies. MCA PSV correlates well with the degree of fetal anemia. It identifies fetuses with moderate to severe anemia prior to hydrops, which require intrauterine transfusion. And how it identifies? Let me tell you that you have to calculate the PSV mom. If it is more than 1.5, then this is your critical level. In clinical practice, it is very easy for you. You can just download the perinatology.com. This is the software. You just have to measure the gestational age and just measure the MCA peak systolic velocity. Enter these figures here and it automatically calculates for you the median peak systolic velocity for this age, and it tells you the multiples of median, that is BOM as well. So there is a fetal anemia if MCA PSV is more than 1.5 mom for that gestation. So how to proceed whenever any Rh negative mother comes to your OPD? Of course, first and foremost is taking the obstetric history in great detail, the history of previous abortions, ectopics, hydrops, fetal or neonatal death, history of blood transfusion, whether she received NTD in her prior pregnancy, and you should see that she has brought the husband's blood group and Rh report with you. Because the husband's blood group makes a lot of difference. If husband is negative, wife is also negative, practically speaking, you don't have to worry about this pregnancy. The problem starts when wife is negative and husband is positive. If wife is negative and husband is positive, we do the indirect Coombs test. Hello, please mute yourself. Support team, please mute everyone. If the indirect Coombs test is negative, the mother is non-immunized. If she is positive, she is a sensitized mother. So how you will follow up and go about the non-immunized mother? You will do indirect Coombs test at booking visit and at 28 weeks. If ICT is negative, give NTD 300 microgram at 28 weeks and repeat NTD 300 microgram post delivery within 72 hours. So this is the NTD prophylaxis. What we are giving as 300 is sufficient to cover the usual feto-maternal hemorrhage, that is the 30 ml of feto-maternal hemorrhage. A prophylactic dose of 300 microgram of NTD immunoglobulin can prevent RHD immunization after exposure to up to 30 ml of RHD positive fetal whole blood or 15 ml of fetal RBCs. So what is the maximum dose of NTD if the feto-maternal hemorrhage is more than this amount? Then what to do? In clinical situations, wherever feto-maternal hemorrhage has occurred in a volume that is not covered by our usual standard 300 microgram dose of RH immunoglobulin, you can give additional vials of RH immunoglobulin at one time. Up to 8 full vials can be administered. This should be given intramuscularly at separate sites every 12 hours until the desired dosage has been reached. An intravenous RH immunoglobulin is also available that may be used in these cases and which provides more comfort for your patient. A single dose of NTD within 72 hours of delivery reduces the rate of RHD immunization by 80 to 90%. Some feto-maternal hemorrhage during the third trimester triggers immunization in 2% of at-risk women before delivery, and this rate was reduced to less than 0.2% with routine NTD immunoglobulin at 28 weeks of gestation. So you have to give NTD when ICT is negative at 28 weeks, at post-delivery within 72 hours, following an episode of antepartum hemorrhage, in cases of spontaneous threatened abortion, ectopic pregnancy, if you are planning to do external cephalic version, if she comes with history of blunt trauma abdomen, and post-invasive fetal procedures. How does this prophylaxis works? The antigen on fetal RBC is not allowed to be presented to the maternal immune system. So this is how it prevents the sensitization of the mother. Overall risk of isoimmunization of Rh negative mother with Rh positive fetus is 16%, and this risk is reduced after NTD administration to 1%. Remember, it is not 100% protection. And why there is a failure of 1%? It might be because you have not given antenatal prophylaxis in the third trimester, you have given insufficient dose, or you have not given it timely, or there is an unrecognized feto-maternal hemorrhage at some point in the pregnancy which the patient has missed, which we have missed as an obstetrician. And an additional reason for RHD immunization is the small rate of spontaneous immunization despite adherence to the recommended prophylaxis protocol. So in other words, prophylaxis is not 100% effective. At delivery, you have to take certain precautions. Don't give methadone. Try to avoid manual removal of placenta. Do early cord clamping and collect the cord blood sample for hemoglobin, direct Coombs test, blood group, and serum bilirubin. So this is what we discussed when the indirect Coombs test is negative and the mother is non-immunized. But if the test is positive and she is sensitized, then how to go about it? Then you have to see whether this is the first pregnancy or this is the subsequent pregnancy in which she gives you history of previous affected pregnancy. If this is the first Rh immunized pregnancy, then the 10% of isoimmunized mothers, they have a child affected by severe hemolytic anemia. But if this is a subsequent pregnancy, then the probability of Rh incompatible fetus is to the tune of 80%, and fetal anemia sets in 8 to 10 weeks earlier than in previous pregnancy. You have to do Rh antibody titers, and this usually correlates well with the severity of disease. The critical titer is average is taken as 1:60. Once ICT is positive, titers are monitored every 4 weekly. If they remain below critical level, then you have to plan delivery at term. If the levels go above critical level, then you have to do follow-up as affected pregnancy. If she gives history of previous affected Rh immunized pregnancy, then maternal antibodies are not predictive of severity of fetal anemia. You have to do monitoring by serial determination of MCA-PSV, should be started at 18 weeks, do every 2 to 4 weekly, and after 35 weeks, there are high chances of getting a false positive result. So if this is the first pregnancy, do serum antibody titers every 4 weekly. If the levels are less than critical, deliver baby at 38 weeks. If the values are more than critical titer level, do fetal assessment by MCA-PSV. There is no need of titers here. If she gives history of previous affected pregnancy, start serial monitoring by MCA-PSV. If the values are less than 1.5 mom, do 1 to 2 weekly monitoring by MCA-PSV Doppler. If the values are more than 1.5 mom, she needs intrauterine fetal transfusion. So to summarize, this is the first antenatal visit of an Rh negative mother. You determine the Rh status of the woman. If Rh negative, determine the Rh status of the husband. If she is negative with Rh positive husband, perform ICT titer. There are 3 possibilities. ICT titer is either negative, is less than 1:16, that is the critical level, or is more than 1:16, which is the critical level. If the ICT titers are negative, repeat titer every 4 weeks, give NTD at 28 to 32 weeks, and repeat NTD within 72 hours of birth. If the values are less than 1:16, repeat titer every 2 weeks, deliver at normal time, no NTD prophylaxis is needed. If ICT titer is more than 1:16, every 2 weeks you have to do the MCA-PSV and look for the features of hydrops. If the MCA-PSV is 1.5 mom or more, you have to repeat after 1 week. If it remains at that level, you have to perform the cardiocentesis and intrauterine transfusion. If the features of hydrops are present, please refer them to a fetal medicine specialist for intrauterine fetal transfusion, and you can plan delivery at 35 weeks or later. When to deliver these infants is a controversial subject. Standard treatment is to prolong the pregnancy until the fetus reaches a gestational age which is necessary for survival. If the history and antenatal studies indicate only mild fetal hemolysis, it is reasonable to proceed with delivery by induction at 37 to 38 weeks. But if she has received intrauterine transfusion, you can decide as per the case after 34 weeks. Important to remember is that you have to document the NTD. If you are given NTD, paste a counterfoil in the patient notes. Tell her and her husband to remember that she has received the NTD, so that if for her subsequent pregnancy she goes to some other doctor, some other place, they will be able to give the history of receiving NTD injection. Always give NTD injection intramuscularly in deltoid region and not in the buttock region. Before giving NTD, check for the storage, the validity dates, the expiry dates, everything. Blood group and Rh factor must be checked for every antenatal patient in the first visit itself. If she is Rh negative, then indirect Coombs test should be done at the first visit and should be repeated at 28 weeks of gestation. Any sensitizing event in a rhesus negative pregnancy must alert the obstetrician towards the possibility of feto-maternal hemorrhage. Adequate NTD prophylaxis can prevent isoimmunization, and if still she is isoimmunized, you have to follow with fetal MCA Dopplers at centers where intrauterine transfusion facilities are available. Friends, remember the fetal medicine here is in the star because this is a teamwork. The management of Rh negative pregnancy, it requires neonatologists, obstetricians, hematologists to have the optimum fetal outcome in these Rh negative patients. So thank you so much for your patient hearing. If there are any questions, I am happy to answer.
Yeah. Thank you so much, ma'am. They were really crystal clear, very crisp messages, practical points, and I really loved the algorithms. It made the understanding so easy. Thank you so much, and over to Dr. Anil for the concluding remarks.
Yeah, very nice lecture by madam. As usual, she is a very good and excellent speaker always, and I love to hear her in every conference. The most important thing which I like in her lecture is that the non-invasive method for monitoring the fetus, that is fixed systolic velocity. That is really a wonderful method to monitor these fetus and timely intervention of these babies to reduce the fetal mortality and morbidity. Thank you, ma'am. Thank you. Even I must thank for revising us the basics and newer recent concepts of management in RH negative to high risk mother. Thank you very much. Thank you.
Thank you, Anil. Thank you, Binal. Now, without wasting much time, let us go towards the second talk. I am also waiting to listen to Ame on a very important topic, that is DIC. So before Ame starts, let me introduce the chairpersons for the next session. Ame, just give me 1 minute. Yeah. So our chairpersons for the session on DIC is Professor Shikha Seth. She is professor and HOD at Government Institute of Medical Sciences, Greater Noida. She has, my God, Shikha. She has got 48 publications in national and international journals, and she has authored chapters in various OBGYN books, and her special interest is gynecology, menopause and contraception. Welcome, Shikha. Dr. Bhavna Khera has done her MRCOG, and she is consultant obstetrician and gynecologist, and her special interest is high-risk pregnancy. I know, Bhavna, you are successfully running this founder MRCOG help, and many MRCOG candidates, you are mentoring them and you are guiding them. So keep doing your good work. She is member of Motherhood Committee, FOXY, and friend, she also has got many publications to her credit. So I welcome both the chairpersons, and they can carry the session forward.
Thank you very much, ma'am, for such a nice introduction. And I will also like to thank all of the organizing team for such a CME on high-risk pregnancy topics, very important topics. And next in the session is the topic which is DIC in obstetrics. And the speaker who is there with us, I think everyone knows him well, Dr. Amey Purandre. He's a consultant obstetrician in Purandre Hospital in KJ Somaya Medical College and associated with many other hospitals also. He has been joint secretary FOXY in 2019 and chairperson of many committees of the FOXY and MOGS also. He has also been a peer reviewer of the Journal of Obstetrics and Gynecology of India, and he has many awards and gold medals to his credit. To name few of them, it is A. Dastur Gold Medal, BN Purandre Gold Medal, Prince of Wales Gold Medal. Apart from these, he has got many awards also. Pride of FOXY Award, FOXY Future Award last year, and the FOXY Young Scientist Award earlier also. So there is a number of things which he has achieved and is there in his credit. I will invite him for his talk, that is DIC in obstetrics, and probably he will be covering all the flaws and the management aspects related dilemmas which is there with us. Thank you. Dr. Amey?
And Amey is a great teacher and orator. So Amey, we are waiting to learn DIC from you. Unmute yourself, Amey. A very popular teacher, huh? Amey is a very popular teacher.
Yeah, thank you, Professor Seth, for those kind words, and thank you, Lakshmi ma'am, for this invitation to talk on a very complex but very important topic of DIC. I can start sharing my screen. I hope my slides are visible to all of you.
Yeah.
So I'll be talking about DIC in obstetrics and with specific attention to diagnostic flaws and management dilemmas. Professor Mahmood Fatala probably one of the greatest philosophers in obstetrics, said that women have a human right to go safely through the risky journey of pregnancy and childhood. A right that should be respected, protected, and implemented. And as women healthcare providers, it is our responsibility to ensure that every pregnancy is a safe and a successful experience. Catastrophes like DIC do occur once in a while, and therefore, as obstetricians, we must be prepared to tackle this crisis and ensure that our pregnant patient goes through it with a safe outcome. So there are three things that I would be basically talking about: pathogenesis, diagnosis, and management. And basically in all these three in obstetrics, there are flaws and there are dilemmas. So what is really DIC? To put it simply, DIC stands for disseminated intravascular coagulation or coagulopathy, and it occurs when finely controlled processes of hemostasis become disrupted. This was first described by the classic work of Striat way back in 1856, where he said that for thrombosis to occur, there should be circulatory stasis, endothelial injury, and a hypercoagulable state. So in other words, to put it scientifically, coagulant responses change from being protective to a maladaptive with pathological consequences, and this tipping of the balance causes DIC. Why is this so important? This is so important because, as all of you here today will agree, that DIC is usually life-threatening. Let us look at DIC from our obstetric point of view. There are various obstetric initiating factors. These are severe complications themselves, and probably DIC is the consequence in the cascade leading of deterioration in these complications. These include eclampsia or severe preeclampsia, postpartum hemorrhage, sepsis, abruption, a missed septic abortion, sickle cell crisis, rupture uterus, trophoblastic disease, hypovolemic shock or massive blood transfusion, amniotic fluid embolism, and intrauterine death. All these can lead to activation of the coagulation system. And this causes DIC, where there is consumption of the coagulation factors, which finally leads to deficiency of these factors, leading to hemorrhagic diastasis. On the other hand, the second pathophysiological event is microvascular coagulation and fibrin deposition. This leads to microvascular obstruction and organ ischemia. This coagulation initiates secondary fibrinolysis with FDP production, and that also causes hemorrhage. From this flowchart, you will understand, on one side, we are dealing with the deadly hemorrhage, and on the other side, we are dealing with the complication of thrombotic obstruction, that is organ ischemia. Indeed, both of them are catastrophic for our patient. So let's look at some of the pitfalls in the pathogenesis. I have already listed the various causes, and one more of them is acute fatty liver of pregnancy and HELP syndrome. Let us look at each of these causes and what we understand or what are the lessons we have learned as far as DIC is concerned in each of them. Amniotic fluid embolism, highly unpredictable and obviously highly catastrophic. The onset is so abrupt that although DIC occurs in about 83% of cases, its diagnosis can be difficult. I'm sorry to say, but amniotic fluid embolism can neither be predicted nor prevented, or no standardized investigations or protocols exist for confirmation. So how do we suspect it? One has to keep in mind that if abnormal coagulation tests are noted in relation to symptoms and signs of acute hypotension or hypoxia within half an hour of delivery, classically called as the postpartum collapse, sudden postpartum collapse, the diagnosis of DIC may be considered as possibly secondary to amniotic fluid embolism. IUFT. Spontaneous delivery occurs within the first 2 weeks, and while marked coagulation disturbances tend to occur after a month of fetal demise. If the fetus is retained longer, up to 25% develop coagulopathy by release of thromboplastin-like material from the dead POCs. Defects may correct spontaneously on an occasion before evacuation but this occurs slowly. Pregnancy complicated by death of one fetus, like what is called as a solitary fetal demise in and the survival of another, leads to dearrangement in coagulation, but these are rare and these pregnancies can be monitored carefully and even we can have a favorable outcome. What about abruptio placenta? DIC here occurs due to the rupture in the maternal decidual artery, what is called as apoplexy, to causing dissection of blood at the deciduo-placental interface. In fact, D. Lee, way back at the beginning of the 20th century, said it is called as a temporary hemophilia. The precise pathophysiology is still not completely known, but what we do accept is that it may be because of impaired placentation, placental insufficiency, and uteroplacental hypoperfusion. PPH. In the 4 T's for PPH, besides stone, trauma, you have, and tissue, you have thrombosis as well. So coagulopathy here arises mainly from the excessive blood loss, consumption of the clotting factors, and further effects of massive transfusion in the setting of acidosis and hypothermia. Moving on to septic abortion. Septic abortion and intrauterine fetal infection can also cause DIC with mechanisms similar to that of septicemia, where an inflammatory process dysregulates coagulation. What about HELP and acute fatty liver of pregnancy, both critical hepatic dysfunctions in pregnancy? In HELP, there is endothelial dysfunction, platelet and complement activation, and this causes release of inflammatory mediators which cause DIC. As far as acute fatty liver is concerned, there is marked hepatic dysfunction. This results in antithrombin 3 deficiency, and that drives the body into a procoagulant state, leading to DIC. Now, from all these, you will realize that there is a pivotal role of thrombin in maintaining hemostasis. It's a balance between coagulation and fibrinolysis. On one side, you have procoagulant actions. On the other side, you have anticoagulant action. And on one side, you have profibrinolytic action. And on the other side, you have antifibrinolytic action. But the limelight of all this lies on factor 2A, or what is activated factor 2A, namely prothrombin. As far as clinicians are concerned, the organ which is the culprit to all this is the placenta. In fact, to put it correctly, the placenta is an activated coagulation system itself. The vascular bed of the placenta contains the fetal trophoblastic cells, and these cells, in addition to supporting pregnancy, have a unique property which, like other endothelial cells in the body, regulate hemostasis. They do so by various mechanisms like tissue factor expression, altered anticoagulation coagulant function, suppression of fibrinolysis, and exposure of anionic phospholipids. Here you can see on one side you have the normal endothelium and the balance being maintained between coagulation and fibrinolysis, and other side you have the activated placental trophoblasts increasing coagulation and decreasing fibrinolysis when it is disrupted. Now let's move on to the diagnosis of DIC. First, obviously, I will talk about the clinical diagnosis. Even though, as I explained, DIC is a consequence or sequelae of various obstetric complications, hence the main symptoms and signs will be those of obstetric complications. Hemorrhagic manifestations may be relatively subtle, ranging from bruising, a purpuric rash, epistaxis, venipuncture oozing, or more dramatic with profuse bleeding from the operative sites and postpartum hemorrhage which refuses to stop. Thrombotic sequelae rarely present in acute DIC and are mainly overshadowed by hemorrhagic diastasis. So what we dramatically see is the hemorrhage, but on the other side, there is also thrombosis occurring, causing organ ischemia. The most common thrombotic manifestations are renal, hepatic, and pulmonary, all of them causing these vital organs to undergo dysfunction and finally fail. The cornerstone for DIC diagnosis has been lab diagnosis, and the diagnosis is reliant on interpretation of several hemostatic parameters rather than an isolated test. It is very important to take this message home that it is a combination of coagulation profile rather than a single test which will accurately diagnose DIC. So the classic findings, as we have been taught, are a prolonged PT and APTT, thrombocytopenia, hypofibrinogenemia, and elevated products of fibrin breakdown, namely elevated D-dimer. What are the pitfalls in pregnancy? All these tests have limitations in pregnancy because the concentration of all coagulation factors, with the exception of factor 11, rise significantly. This results in marked shortening of the PT and APTT. Any consumption of coagulation factors, therefore, would prolong these measurements, but the overall clot time may still be within normal limits, that is, in the non-pregnant range. Hence, it is important to assess serial changes and not a single value in the PT and APTT to be aware of the ongoing DIC process. The physiological thrombocytopenia of pregnancy needs to be considered before interpreting the platelet count in DIC. Again here, a serial drop is more significant than a single measurement. Fibrinogen is often thought to be one of the sensitive markers for DIC in pregnancy. But in 2004, Manton and colleagues said that it is not a sensitive marker. And why did they say so? Because the levels can double from non-pregnant states. It confounds the interpretation of normal fibrinogen levels in a patient suspected of having DIC, and fibrinogen can be used as a predictor of PPH severity rather than a sensitive marker of DIC in pregnancy. There has been a change in thought with these observations, and I will discuss them towards the end of my lecture when I talk to you about what is new in 2021. D-dimer. D-dimer is a marker of increased cross-linked fibrin formation. It is, friends, inherently high in normal pregnancy, and an increased level therefore cannot be always due to DIC. Single high D-dimer level is not meaningful therefore, but a continued increase may help in a clinical situation. Accuracy of a high D-dimer level hence is not well standardized. Normal range of tests used for diagnosing DIC in a non-obstetric setting cannot therefore be immediately extrapolated to pregnancy associated with DIC because of the various pitfalls that I have already discussed. Hence, the moral of the story is serial or repeated coagulation tests are more helpful than a single time point of assessment. Let us look at the DIC score, which has been proposed by the International Society of Thrombosis and Hemostasis, which is called popularly as the ISTH score for DIC. It's a 4-step process. Number 1, you start by assessing the risk. Does the patient have an underlying disorder known to be associated with overt DIC? The disorder list I had already enumerated at the beginning of the lecture. So if it is one of those, then if yes, proceed. If no, do not use this algorithm further. So if it is yes, order global coagulation tests, what we popularly call as the DIC profile, which is a combination of prothrombin time, platelet count, fibrinogen, and fibrin-related markers. Score the test results. Each level or each marker has a score. Platelet count, elevated fibrin marker using D-dimer or FTP, prolonged prothrombin time, and fibrinogen levels. Once you quantify, you will get a calculated score. If the score is more than 5, it is compatible with overt DIC, but you need to repeat the score daily. If the score is less than 5, it is suggestive of non-overt DIC and you need to repeat it probably 48 hours later, maybe earlier, depending upon the clinical situation. There are certain specialized tests in DIC as well. These are the thrombin, antithrombin, or what are called as the TAT complexes, fibrinopeptide A, antithrombin 3, protein C, soluble TM. However, even though these are present, these are known, presently they are practical and expensive in the acute setting of DIC. Let me show you a little bit about clot lysis profile in PPH. You can see there are three graphs, A, B, and C. A is what happens in a normal vaginal delivery. B is that what happens in a fibrinolytic state, that is in PPH, and C which occurs in a hyperfibrinolytic state. So what here you understand is that in about 8 out of the 20 patients in this paper, there was a normal pattern of clot lysis. And in the B chart, there is no lysis of the clot because of the hypofibrinolytic state, while in the C group, there is hyperfibrinolysis. So each patient over a period of time will have a different score as far as clot lysis is concerned. And this may be useful, especially in refractory PPH, where you want to know whether there is a hyperfibrinolytic mechanism or a hypofibrinolytic mechanism, because then you can give the particular drug according to the clot lysis profile. Let's move on to management. The primary approach in management to DIC is to address the obstetric abnormality. Obviously, once this is corrected, hopefully the DIC will usually subside. Additional supportive treatments that are specifically aimed at the coagulation abnormalities are required in some cases. The key to management of DIC is replacement of blood products. And the guide to blood product replacement in massive obstetric hemorrhage, the following important do's and don'ts must be kept in mind. First of all, control the bleeding using surgical and or radiological interventions. Stop the hemorrhage, arrest the blood loss. Aim to try and restore the circulating blood volume using fluids and blood products. Control exacerbating factors for abnormal coagulation, especially hypothermia and acidosis. And blood product support is the mainstay. You need to give red cells. When none are available, use O negative cells. Use the blood warmer to avoid hypothermia. Replace red cells as required to maintain the circulating blood volume. Obviously, the blood should be available, which should be RH compatible, and usually within half an hour. FFP, transfuse 1 unit of plasma to every 1 unit of red blood cells. And aim is to keep the PT-APTT less than 1.5 times the norm. Platelet transfusion, 1 to 2 adult doses after 1.5 to 2 blood volume replacements. It's equivalent to 8 to 10 bags of red cells. And the platelet count that we must aim for should be more than 50,000 at least. Fibrinogen, cryoprecipitate should be given. Dose is usually 2 donation pools. The fibrinogen concentrates are about 4 grams, and the aim is to obtain a fibrinogen level over 1 gram. These are higher levels, and once we achieve these, once we aim for these, we will be able to tide over the hematological abnormality, and the patient will be usually saved. Let's talk about a few other agents which can be useful at times. Heparin has been used in the treatment of DIC in IUF. Effectiveness has not been negated, neither its benefits substantiated. Improvements in lab abnormalities have been noted, but whether this improves clinical outcome is really unclear, and it cannot be recommended in patients who are bleeding or at high risk of doing so. This paper came way back in 1970. Of time. Antithrombin 3 has been used as a monotherapy in patients with obstetric DIC. Level of less than
ऐसा एडवांस दीजिए कुछ दे दिए हमारे पास था 200 आपका 100 रुपया बचा 300.
Can I request the technical people to mute there's some disturbance. So antithrombin or placebo was given to severely pre-eclamptic patients in a dose of 1,500 units per day for a week, along with continuous infusion of unfractionated heparin. What they observed was there was an improvement greater in the antithrombin group in terms of the biophysical profile and the coagulation parameters, and was not associated with adverse events. These were initial trials and further need to be warranted, but Kobayashi has revolutionized the treatment with antithrombin, especially in the obstetric population. What about activated protein C has also been used effective in patients with sepsis and abruption-induced DIC. Now, this is to be given IV for 96 hours. Compared to placebo, this treatment has achieved risk reduction, and serious bleeding, however, is higher with this because, again, it is an anticoagulant and can provoke bleeding. What about massive hemorrhage? Obviously, aggressive resuscitation is the key to positive outcome. Massive amount of blood loss is most common in PPH, and surgical control, we all agree and know at times we are helpless and can be difficult, and where occasionally drastic measures like hysterectomy have to be performed. The usual management of PPH, as we know, begins with medical, then mechanical or compression, then surgical methods. But in all these cases, blood product support should be started and maintained even in large quantities. Therefore, it is useful to have a hospital policy for massive blood transfusion with regular drills for relevant personnel to be constantly prepared. There is now a WHO endorsed, and which we are considering in the Manyata initiative as a policy for massive blood transfusion, and I will talk about it a little later, where your team will be involved if this arises on an occasion. Moving on to activated factor 7, we are seeing increasing beneficial experience, especially in intractable bleeding and massive obstetric hemorrhage. At supraphysiological concentrations, recombinant factor 7A, which is available, directly activates factor 10 on the surface of locally activated platelets. A response rate as high as 90% has been recorded in massive obstetric hemorrhage, and the effectiveness is measured with various endpoints, has shown benefit with reduced transfusions, avoidance of uterine artery embolization need, and the need for hysterectomy, as published in the British Journal in 2007. But with active factor 7, there are several unresolved issues. We really don't know what is the optimal dose. Some studies have said as low as 15, while some studies have said as high as 120 micrograms per kg. As you can see, there is a wide variation, but generally it is accepted as a midpoint between these two, about 75 to 80 micrograms per kg. A platelet count over 1 lakh and those with less severe coagulopathy are more likely to respond. So therefore, is early transfusion indicated. Acidosis and low fibrinogen levels retard the optimal function, and therefore again, if you have to give activated factor 7, it would respond best if you give it early in the course rather than when the patient has deteriorated. It has been associated with thromboembolic complications, and still it is a costly affair. Obviously, in today's world, without talking about COVID, no lecture would be complete when you are talking about the hemostatic and the thromboembolic complications. As we all know, thromboembolism and thrombosis go hand in hand with the COVID pathogenesis. In this paper, which has been published just last month, where a systematic review and critical analysis has been done of the hemostatic and the thromboembolic complications in pregnant women with COVID, where close to 1,060 odd women were evaluated, they found that arteriovenous thrombosis was seen in only 3 patients. DIC was seen in 7 patients, and further 3 had coagulopathy but did not meet the definition of DIC. Most of these patients did well, but 17 of them died, in which DIC was reported as a factor in 2 of them. This paper went on to conclude that coagulopathy and thromboembolism are both increased in pregnancies with COVID, and therefore detection of the coagulopathy may be useful in identification of women at risk for deterioration. When you look through the intricacies of the paper, there are certain important points that we must remember that will be useful in our practice. RCOG has very clearly told us all pregnant women with confirmed or suspected COVID should receive prophylactic low molecular weight heparin unless birth is expected within the next 12 hours, and we need to continue this for at least 10 days following discharge. Despite elevated D-dimer, which is seen in COVID-19, DIC is infrequent in pregnant women, and therefore, as I told you earlier, there are pitfalls of D-dimer in pregnancy. COVID confuses the matter further, and hence this cannot be used for prognostication of DIC. To diagnose coagulopathy in pregnant women with COVID, therefore, a panel of CBC, D-dimer, FTB, clotting screen, and fibrinogen needs to be done. We need to then calculate the pregnancy-related DIC score, which has got modified just the beginning of last year before COVID set in. And I will talk about you of this modified score relevant to obstetrics in a minute or two. And this score is especially useful because if the woman needs delivery, it can tell us about the blood product support. Friends, one very important point I want to take home for you to take home today, and that is don't use tranexamic acid when there is DIC and COVID, because recovery from DIC is dependent, as I told you, on endogenous fibrinolysis to break down the disseminated thrombi. This is inhibited by tranexamic acid, which is an antifibrinolytic drug. If there is bleeding associated with DIC, give blood products and not tranexamic acid. Increased thrombosis risk in pregnancy is present. We all know pregnancy itself is a prothrombotic state, and therefore you must have a high index of suspicion of venous thromboembolism in these patients of COVID in pregnancy. Women near delivery, you need to do the coagulation parameters and platelet counts, as these will have potential implications for delivery and guide you for the need for delivery. And obviously take your friendly hematologist guidance on an individual patient basis so that you will understand the intricacies of what is happening in the hematological system. You will focus on obstetrics, he will focus on DIC, and finally you will get a good outcome. I told you that the DIC score has got modified, and now we have the modified DIC score. If you look on the first side, we have the old score, and that looked at the platelet count, the prolonged PT, fibrinogen, and the fibrin split products. A score of more than 5, we said the patient had DIC. But there is a pregnancy modified score, which looks at the platelet count in a graded manner, the PT, where more points are given. Prolonged PT, as I told you, we don't look at it per se, and fibrinogen levels, and we don't look at the fibrin split products because D-dimer is no longer considered helpful. Why is this better than the older score? Because it helps us identify patients who are at risk of DIC. It does not just diagnose DIC. It's likely to therefore reflect the severity of the obstetric hemorrhage that is going to fall on the patient. Hence, we know that if we are able to identify this obstetric hemorrhage, we will be in a better state because this hemorrhage is a major contributor to mortality. And if we are delayed in diagnosis, our patient is certainly not going to do well. This score has helped us in utilization of an effective severity of the clinical severe obstetric hemorrhage which is caused by DIC. I talked to you about the massive transfusion protocol. This is what we are trying to evolve, which will be then tweaked at every obstetric facility. You are the director along with your anesthetist or your critical care specialist, depending upon your level of infrastructure. You activate this protocol. You identify a runner who may be the anesthesia technician or a person in your team who then goes to the blood bank and comes with the blood products. You have a reporter, one who calls up the blood bank, calls up the lab, notifies the rapid response team in the blood bank that you need blood accurately, tells you repeatedly what the lab values are, and then once you don't need the blood, deactivates this protocol. You need to first start by screening for DIC, and therefore that would involve the barrage of investigations beginning with hemoglobin, hematocrit platelets, DIC panel of PT-INR, PT-TT, fibrinogen D-dimer, and ABG with metabolites like calcium, potassium, and glucose. And you need to then see how severely the patient is affected. Initially, blood package 4 units of RBCs and 4 units of FFP. Repeat the test as I told you. If she is continuing to bleed, you need to again give 4 RBCs, 4 FFPs. You may have to give 1 apheresis of platelet unit and 1 dose of cryoprecipitate. If she improves, obviously you deactivate the protocol. When do you activate the protocol? You activate if the INR has increased to 1.5 or more, where you begin by giving 2 units of FFP. If the platelet count drops below 1 lakh, give her a platelet unit. And if the fibrinogen falls less than 200, give her 1 dose of cryoprecipitate, which is usually 10 units. Remember, friends, these are early values. They may not be that bad, but you must start acting when things are better rather than when things are worse. Because if you don't act, the deterioration will occur very rapidly. So, in your own institute, in your own nursing home, develop this massive transfusion protocol and tweak it according to your resources. Identify people who will help you when you are in need and do their duty and their tasks as denoted here. You are the director, you have an assistant, you have a reporter, you have a runner. So to conclude, the key to management is early recognition and timely intervention. Diagnosis with the modified score and serial testing will increase precision. Treatment is blood product replacement and placental removal. New therapeutic agents and diagnostic markers are more effective approaches, but we must make them practically and cost-effectively relevant. In massive blood transfusion, a well-prepared approach is crucial, and collaborative trials to include pro-hemostatic agents could translate into improved outcomes. I leave you with words of the Gita. And I think these words probably Krishna said not to Arjun, but to the obstetrician, that crises are integral to obstetrics, and those who rapidly correct it and counteract it will survive and succeed. Thank you all for a patient hearing.
Thank you, Dr. Amey. It was really a very, very crisp and wonderful presentation. And I must congratulate you for doing justice to such a complex topic, which is really a nightmare to all obstetricians. So just to conclude, although you have very beautifully cleared everything, starting from the basics, what are the conditions which lead to DIC, what is the pathogenesis behind it, and then what are the things, tests we are required to do. Very aptly said, we need battery of tests to actually delineate the diagnosis of DIC. It's not just one marker which will lead to this all thing. And also we need to have a series of tests. So this is very good, very nicely pointed out, and this is very much required.
and then anticipating the condition, early recognition, and timely intervention with a teamwork. May having a hematologist, critical care specialist along with us would definitely lead us to win this situation, which is really tough to conquer. But definitely, with your presentation, with the knowledge we have gained from your sides, we will definitely be able to conquer it. Thank you so much for your very crisp talk.
Thank
And
you.
I would also like to congratulate Lakshmi ma'am for her nice presentation and this beautiful webinar from the ISOPA Vidarbha Society. And thank you so much, ma'am.
Thank you, persons, for those kind remarks. And I hope I have been able to simplify this complex situation so that we have more clarity when we are able to manage these situations.
Yes, sir. That was really perfect.
You have really simplified. That is what I was telling. You are a great teacher. Usha ma'am, you want to comment? I can see madam is there with us. She is logged out. Okay. So now let us move to the panel discussion. We are having a panel on a very common topic, thyroid disorders in pregnancy, and yet we have so many queries and questions. So let me introduce the chairpersons of the panel discussion, Dr. Ruchika Garg. She is the gold medalist MRCOG and she is currently the associate editor journal of TOG journal. She is in the editorial board of Journal of Midlife Health. She has received various awards. She was joint treasurer of AICOG 2016 and we still have very fond memories, Ruchika, of that AICOG, and we really wish to come back again to your Agra. So friends, she has got many publications to her credit. So welcome Ruchika for this panel. The second chairperson is Dr. Rashmi Bhaisare, my colleague, my friend, who is really working very hard in this COVID crisis because she is officer on duty in Nagpur Municipal Corporation. Very busy, but she has taken some time to log in for this webinar. She is also appropriate authority of PCPNDT and MTP at Nagpur Municipal Corporation, worked as a research officer in WHO projects, on various WHO projects I will say, because I can see there are many projects you have enumerated. So welcome Rashmi, and I request chairpersons to take forward the panel discussion, the session.
Thank you, Lakshmi ma'am, for this opportunity. It's my proud privilege to be part of this panel, and I am feeling very humble to introduce Dr. Tarini Taneja madam. She doesn't require any introduction. She is the director of Taneja Test Tube Baby Center at Muzaffarnagar and Delhi. Am I audible?
Yes,
she's editor of ISAR Delhi chapter. Okay, thank you, ma'am. She's board member, Journal of Obs Gynae Research and Practice. She was the organizing secretary of North Zone Yuva Foxy 2012. She is also the organizing chairperson of UPCOG International 2020. She has received so many awards to her credit, including the Bharat Gaurav Samman Award. And she's the chairperson of ISAR Delhi State. She's president-elect UP State Obs Gynae Society. And she's received President of Abdul Kalam's Excellence Award. So many friendships she has to her credit. She's president-elect ISPA Delhi chapter, and she has been the president of Muzaffarnagar Society, and she's founder of Delhi chapter of IAG, and she has been the press committee chairperson for the year 2013 to 15. And currently she is the president of an NGO also, Manzile Rahat, for female feticide. And she's RCOG associated member. So the mic is now yours, Tarini madam. Welcome to you.
No, let Rashmi introduce the other moderator and the panel expert. Rashmi, are you there?
Yes, ma'am, I'm there.
Yeah.
Am I audible?
Yeah, you are audible, Rashmi.
Thank you, Lakshmi ma'am, for this opportunity. Actually, thank you very much. So here I am to introduce Madam Dr. Ritu Dargan, Madam. She is the MD. She is the director of the Integra Specialty Clinics, Hamla, Nagpur. She is a consultant at the Nelson Mother and Child Care Hospital, Dhantoli, Nagpur. She did her graduation and the post-graduation from Mahatma Gandhi Institute of
Rashmi, your network has gone.
Yes. Ma'am, should we start? I'll introduce the panelists also.
No, let me finish. Ritu is my friend and colleague. She has done her postgraduate diploma in medical legal system from Symbiosis, and she has also got diploma in emergency obstetric care from Sweden. Friend, she was a very popular teacher. She was associate professor at MGIMS Sevagram, but then many years back she shifted to Nagpur. She is master trainer for emergency obstetrics, and she is technical consultant for Mamta Health Institute for Mother and Child Health. She is a great academician and has got many publications, presented many papers in the national and international conferences. I am so happy that Dr. Jaisavar has agreed to be the panel expert for this very interesting panel on thyroid disorders and pregnancy. As you can see, she has got n number of awards, so please excuse me if I don't read out all the awards for you. And she has got so many office bearers position. She was vice president of LOGS, secretary of LOGS. She is currently the member of so many associations, and she is MCI inspector, external examiner for undergraduate and postgraduate exams. She is visiting professor at BP Koirala Institute of Health Sciences, Dharan, Nepal, and visiting professor for ICOG. I am really happy and proud of you, Dr. Jaisavar. And she has got more than 100 publications. So century marli hai aapne. More than 100 publications to her credit. So we are really looking forward to a great panel and your expert comments during the panel discussion. Yes, Ritu, you can take forward.
Right, ma'am. डॉक्टर तारिणी मैडम, आप इंट्रोड्यूस करने वाले थे. Is Dr. Tarini there? Okay, I'll start with the introductions. We have our first panelist is Dr.
I'm taking the introduction of Dr. Ashti Dikatke. Yes. She's MD, FICOG, FMES, and she's the professor head of the department Ujjivan Grant Government Medical College, Mumbai, and she's a very academic and have many research and editorial and author, 85 publication, 171 citation, my God, in national and international. She has contributed chapter in Foxy Focus, and she's co-editor book Foxy. And she has many awards and appreciation recipients of many. She has been appreciated by the General Secretary of United Nations, Honorable Ban Ki-moon. She has been awarded Chief Minister by Chief Minister conducting camps, Mahila Ratan Award, the Best Superintendent Award and Associate Appears. She's a Rajiv Gandhi Excellence Award. And she has got the administrative position, and also she is speaker for various health related talks on digital media and television. And she's a many health camps have done in rural, tribal and urban places across Maharashtra. So Dr. Rashiri, she is a very, very academician. And the next one, Dr. Ritu, can you display the other slide?
Ma'am, it's displayed.
Friend Rajeshi Katke is currently the professor and head of the department of JJ Group of Hospitals, Mumbai, a very keen academician. Oh. And you must have seen her so many FB posts. She is always there for the poor patients, give personal attentions, and she has done so many rare surgeries in the capacity of professor and HOD. Proud of you, Rajeshi. Yes, please carry.
And the next panelist, the Dr. Bharati More. She is my good friend. She's a MD, FICOG, CIMP. She has been graduation, post-graduation from Lokmanya Tilak Municipal Medical College, Sain Hospital, Mumbai. She is practicing obstetrician and gynecologist in Navi Mumbai since 1990. She is consultant and medical director at Shakuntala Bemans Hospital and Fertility Center, Airoli, Navi Mumbai. She is an honorary gynecologist, Mathadi Hospital Trust, Kopak Kirani, Navi Mumbai. She is past president Navi Mumbai Obstetric Gynecological Society since 2013 to 15. She is organizing chairperson MOGS Conference 2014 in Navi Mumbai. She is a member of the following Foxy Committee, Adolescent Health, Medical Disorder, Oncology Committee, and now that she has been President IMS Navi Mumbai 2015 to 2018.
Thank you,
So,
Tarani.
yeah,
Thanks for those words.
Welcome,
and
Happy.
the next is Dr. Manoj Chelani. Even she is a very good friend of mine. He is MBBS
Hi,
BGO.
Lakshmi.
Hi, hi.
Thank you.
And he is the director Ayush ICSI Testing Baby Center. He has been chairperson elect CGI ISAR 2022 to 24. Uh,
हो, हो, हो. Just सुरू केलं, yeah.
and he is the secretary IMA Raipur 2009 to 2010. He is the past president Raipur Obstetric and Gynecological Society. He is the president Indian Menopause Society Raipur chapter 2018 to 2022. He is the organizing secretary SAFOM IMSECON 2017. He has been the founder chapter secretary Indian Fertility Society Chhattisgarh. He has been the recipient of Emerging Chhattisgarh Award for Best Testing Baby Center, many other awards at her credits. He has been the recipient of CIMS Healthcare Excellence Award, recipient Indo Global Healthcare Summit Award Hyderabad for Best, and he has been a recipient of Global Healthcare Excellent Award 2014 the Delhi. He has been linked in Golden Book of World Record for maximum number of embryo transfer. Has been invited guest faculty of various international national state conferences. So congratulations, Dr. Manoj, for being linked in the Golden Book of World Record for maximum number embryo transfer. I'm really proud of
Welcome,
you,
Manoj.
Dr.
I am
Manoj.
happy you could make it to our Vidarbha ISOPA platform. I was
Thank you,
really
ma'am. Thanks for
pestering him.
inviting
"Manoj, एक
me.
बार तो आजा." It is not going.
So
Our next
over
panelist
to
is हाँ,
over to you, to Dr. Ritu now for the.
Yes. Yeah, our next panelist is Dr. Sujata Dalvi. She's a leading practitioner at Mumbai. She is also consultant at Global, Saifi, Bhatia, Elizabeth, and Bruxmani, Lyingen, and Jain group of hospitals. And ma'am has been a very active member of the Mumbai Obs and Gynae Society. And she's also the first joint secretary of MOGS. Ma'am, can we have the next, please?
welcome Sujata, and she is working a lot for the our Yogi Journal.
Thank you, Lakshmi. Thank you so much. Our next panelist is Dr. Vinita Avasti, who's she's done her MBBS MS from Maharani Lakshmi Bai Medical College, Jhansi. She received FICOG at Bangalore at AICOG 2019, and she's a consultant at Manas Medical Center at Kanpur. She was also the joint organizing secretary for AICOG Lucknow, and also the joint secretary Kanpur Obs and Gynae Society. And she's also the joint organizing secretary of the WW.con held at Nagpur in 2018. Welcome, Dr. Vinita.
Welcome, Vinita, and your AICOG was one of the best AICOG. We still have fond memories of your AICOG.
Our next panelist is a dynamic person, Dr. Richa Sharma, and she has a long list of awards to her credit. And she's presently the professor at UCMS College and GTP Hospital, Delhi. She's also the chairperson elect for the FOXY MTP committee. She's the national corresponding editor for GOGI, and she's also the AO endoscopy committee chairperson also for 2019-21, joint secretary of IAGE Delhi chapter, and also she was being the skills workshop coordinator. Welcome, Dr. Richa, and please excuse me if I don't list out your awards. There are too many of them, and I think all of us have been humbled by the number of awards that you have received.
Yeah,
Welcome.
I would just like to mention her publications. Ritu, she has got more
Yes,
than
yes.
25 publications, presented more than 90 papers. And Richa, you are really a humble, silent worker of Foxy. I am so happy and congratulations for getting elected as MTP committee chairperson of Foxy. So Ritu and Tarini, the floor is all yours. You can start your screen sharing.
Thank you so much, Dr. Lakshmi, for giving the opportunity. I really want to congratulate you for your first session, that is the cyber crime. For the youth, it was wonderful, eye-opening, mesmerizing. And also this one, your RS negative, again, the brainstorming lecture. You are really awesome, wonderful academician. I'm really thankful for giving the opportunity at this ISOPAP chapter.
So a very warm welcome to all the panelists and our esteemed panel expert, Dr. Jaiswal also.
Thank you, Dr. Lakshmi. So much. I should cover this wonderful CME, and I'm happy we are sharing with this platform. And Dr. Tarini, definitely you are such a great person. I think Dr. Tarini and Ritu will go to cover all aspects of thyroid problem. You know, the hyper or hypo, both conditions are quite problematic and create problems. So Dr. Tarini, please. Thank you so much.
Thank you, doctor.
So, like we all know, just a brief introduction about thyroid dysfunction in pregnancy. Pregnancy, we know, places a unique demand on the thyroid gland, and it's basically a stress test for this master regulator of metabolism. And as many as 5% of pregnant women experience some degree of thyroid dysfunction, putting themselves and their babies at risk. Now, a lot of times thyroid dysfunction is overlooked during pregnancy because of the non-specific symptoms and the hypermetabolic state of the normal pregnancy. Now, as obstetricians, most of us are always worried about preeclampsia, growth retardation, gestational diabetes, preterm, and somewhere one disorder tends to fall off the radar, and that is what we are going to be emphasizing today. That is the thyroid dysfunction in pregnancy. So, how does pregnancy affect the thyroid physiology? Just a brief. I wouldn't give this as a question, or if anybody is willing to take it up, it's more than welcome. Or if you want, I can just go ahead with it. And then we can.
I think, Acha, you would like to say something to us?
Yeah, I'll just, it basically we all know, because I would like to focus more on the cases and have discussion more on the cases. So just a brief introduction. We know there is a change in the level of thyroid binding globulins, total 3T, T4 and TSH during the normal pregnancy. So we know HCG basically cross-reacts and stimulates the TSH receptors, increasing the production of T3, T4, which leads to a negative feedback causing a fall in the TSH levels. Along with that, there is increased estrogen production, which acts on the liver and stimulates an increased production of the thyroid binding globulin. So again, there is a total rise in the total T3, T4. Along with this, there is also an increased demand for iodine. One is because of the increased glomerular filtration rate, there is increased losses by the mother. And also after 12 weeks of pregnancy, the demand by the fetal thyroid gland also. So all these factors contribute to leading to a thyroid dysfunction in pregnancy.
Can I say something, Ritu, here?
Yes, ma'am, please.
Yeah, physiological. You said there is decrease in the TSH values even otherwise, and that is the reason the TSH values which are taken during pregnancy are much lower as compared to the non-pregnant levels. Yes. And we have different values in the first, second, and the third trimester. So that happens only because of the physiologically TSH values are little less. That's all I just want to tell you.
It's a state of hypothyroidism.
That's right.
So now we all need to deliberate now. So I'll come. Well, the first thing is, what is, Dr. Tarini, would you like to take these questions?
Okay. So I welcome all the panelists. So what is the commonest thyroid dysfunction seen in pregnant women? This question. And what is the prevalence? So anybody can take?
I think we have in the dysfunction of the thyroid. So one is a hypothyroidism and second is a hyper. Basically we are more with the hypothyroidism, but to go clinically, as rightly both of them said that the TSH values, they have been ultra sensitive and it has been increased in that. So a subclinical hypothyroidism during pregnancy, that can give rise to most of the complications in that. And the second is the hyperthyroidism. The prevalence will be around we say around 20 to 30% of the thyroid contributory dysfunctions. It will go to the hypothyroidism. And hyperthyroidism, specifically, it is autoimmune disorders which is going into that, like a Graves' disease, or it may be associated with the hyperfunctioning of the thyroid gland, and that is of a lesser amount. It is around 5 to 8% of the total thyroid elements during pregnancy. So this is how we should go ahead with that.
May I add something?
Yeah. Sure,
Yes.
sure, please.
Hypothyroidism is more common during pregnancy.
Yes.
Hyperthyroidism is not as common because of if a patient is already having hyperthyroidism, the continuation of pregnancy is not very easy. So the patient we are seeing in the pregnancy antenatal patient, they are more on the hypothyroid side. बिकॉज इन जो पेशेंट को हाइपरथायराइडिज्म होता है वो प्रेगनेंसी को उस स्टेट तक पहुंच ही नहीं पाते हैं. ओवर्ट हाइपरथायराइडिज्म, अनट्रीटेड ओवर्ट हाइपरथायराइडिज्म. So most of the patient we are dealing with the hypothyroidism either subclinical or overt.
So overall incidence is more of hypo rather than the hyper.
Okay. Yes. So commonest I feel is the hypothyroidism, and in hypothyroidism the most common is subclinical one. And subclinical is around 2 to 5%, and overt hypothyroidism is nearly 2 to 10 per 1,000 pregnancies. And the commonest reason for hypothyroidism in pregnancy is the Hashimoto's, which is the commonest one, which causes hypothyroidism during pregnancy.
Can I talk here?
In overt hyperthyroidism is rare. It's just 0.2 to 0.7%. And if we see the overt, the 95% is because of the Graves' disease.
Graves' disease.
Agree.
And postpartum hypothyroidism is more common because of the thyroiditis.
So can I add something more?
Sure, please.
Already it has been mentioned. Already it has been mentioned that hypothyroidism is more common than hyper, because in hyper the patient getting pregnant is difficult. But and as somebody said, like overt hypothyroidism is seen rather than clinical hypothyroidism. The causes, as one rightly said, Hashimoto's as an autoimmune thyroiditis is most common. But at times, if you take a history, there could be a history of partial thyroidectomy done, or there was a radiotherapy treatment taken. So the history has to be taken. But most of the time, it is an autoimmune thyroiditis that is seen in pregnancy. So we all decide upon the TSH values, and what I would suggest at the start of the panel, that TSH should be done compulsory in the antenatal profile that one is asking for when the patient comes for registration.
Thank you. Now I can see the thyroid problem is so common. So everybody is bubbling their experience or knowledge, because every next patient is of the hypothyroidism, usually the patient of the infertility, because we are considering the patient infertility. So every next patient coming with the hypothyroidism.
Madam,
So
I agree.
Agree, because infertility also, when we investigate, even
clinical hypothyroidism.
So Dr. Binita is rightly said subclinical or overt. So why does it very difficult to diagnose the subclinical there's a hypothyroidism in the patient with the pregnancy, especially in the first trimester?
Ma'am,
that is why,
because in the subclinical hypothyroidism symptoms are not very clear, and even mild symptoms are there, they can get the mimic with the pregnancy symptoms also. So if there is a history of some bad obstetric history or some miscarriages, even in the primary, we should screen all the patient for thyroid function, TSH. And in those patients where the history is more prominent for miscarriages or bad obstetric history, we should go for the antibody test also if TSH is within the normal
range. Even if it is normal.
Or if it is within the 2.5 and TPO antibody is positive, then you can start the treatment and you will get the result positively.
Correct.
I would like to add one thing is that even if you are going with the TSH, we should go for the free T3, T4 levels also. That is the one thing which can give rise to, give the exact idea about the thyroid function. And rightly she said that there has to go to look after the autoimmune disorders, go for a TPO antibodies and free TPO and TPO antibodies. Whether the patient has an autoimmune disorder.
We can't depend only TSH level. Whenever we start
T3, T4, FT3.
That file should be done.
T3, free T4 and TPO antibodies.
Dr. Ashri Kharkar, Dr. SP Jaswal very rightly said, we should also measure the free T4 is also very
sensitive.
T4, So I just wanted to look, somebody talked about the antibodies. So what is the significance? Some patient is having the antibody titers more, TPO. So what does it signify?
Madam, what they say, if you look to the view of the endocrinologist, what they say,
she also come as first, second, and third trimester miscarriage. There are more chances of premature delivery. There is a chance of small for gestational age, and there is more chance of abruptio placenta and preeclampsia. And it will support the brain development of the baby. There's
Voice
the
is cracking. I don't know why.
I can't hear well. There are two people talking.
अलग से बीच में
Can we
निकलना
have just one person speak at a time, please?
ये उससे रिलेटेड नहीं है कुछ डिस्कशन चलते चलते
डॉक्टर शिखा शेठ, आपका ऑडियो ऑन है.
So, like antibody signifies, suppose if the patient is having the high titer, definitely we have to look for the other autoimmune disease, maybe related with the diabetes, SLE, or suppose she has developed the antibody in the first time, as the first time is a pregnancy induced, then the later in the future life she can have the hypothyroidism.
Generally,
so we have to like monitor her periodically for that also. Anyway,
patients with the autoimmune and TPO antibodies can go rise to the recurrent pregnancy losses. There we generally pick up the TPO antibodies.
Very right, valid point, Doctor.
Can I add the point here?
Why? Sure. Why it's written Adit More, Bharti? Why is your name not there? There's Aditya More. Dr. Bharati, yes.
They are all on our kids.
Carry on, Dr. Bharati.
Ma'am, in the clinical setting, we had seen more patients with RPL with the antibody positive. Although their TSH level was within the normal range, when we go for the TPO antibody, they become positive, and the treatment was given. The pregnancy was successful.
That's why the level
wide range
is important.
Wide ranges of the disease of hypothyroidism. So,
and there are more chances of apreuptial placenta and preeclampsia, and small for gestational age.
Right.
And it does affect the brain development of the baby. There's a chances of IQ affecting the IQ level also. And most family it will affect patient will have difficulty to conceive. So infertility is the first thing. And then there's a first, second and third trimester miscarriages mostly seen with the hypothyroidism in pregnancy.
Very right. So, Dr. Ritu, can we have the next slide? Dr. Ritu, are you there? Dr. Ritu?
No, ma'am.
She is not there. She will be there. Maybe they muted or some internet problem because she is displaying from her side.
Yes,
she has shared. She has shared the presentation.
She has lost the connection because the screen sharing is also stopped.
Yeah, I think some technical glitches with this also, I am also getting some.
Screen sharing is not there.
No,
shall we read out the question?
So here we have discussed about the complication can occur with the thyroid dysfunction because the hypothyroidism is more common. So we are more related with the hypothyroidism. Patient can present with the so many, as Dr. is already enumerated, complication which can occur due to hypothyroidism. Hyperthyroidism definitely is less problematic, and in that condition patient doesn't conceive. So we don't face much these conditions. Rarely, yes, we face also.
Dr. Ritu, are you there?
Yes, ma'am. Yes, ma'am. I'm back. There was a network issue.
Yeah.
Right. So I think we've all had a very good question. Disorder is more common with the hypo or hyperthyroidism. And coming to the deleterious effects of hyperthyroidism on pregnancy, I think we've all been why it is so important, why it is important to screen these women. So I'll just move on to the first case that will come first. First case is a 26-year-old lady. She comes with a pregnancy of 6 weeks. She's presented with hyperemesis. Her ultrasound shows a twin gestation. Her TSH levels are 0.04 with a rise in the free T4 levels. So what is your diagnosis? I'd like to place this question to Dr. Rajshri, please.
She has a twin pregnancy. In multiple pregnancy also, suppose this placental hyperplacentosis, they can share the alpha subunits with the TSH. So that TSH, it may, gets, the level can get altered. But basically, if there is a free T4 level, and if it is associated with the either reduction of the free T3 or elevation of free T3, then it will be a thyroid dysfunction. Otherwise, we can say that because of this multiple pregnancy also there is a dysfunction at the thyroid level. for that,
Right.
I would like to say that free T3, free T4 and TSH can label in cases of hypothyroidism as a overt hypothyroidism unless you rule out the twin, multiple pregnancies or the polyhydramnias or hyperplacentosis. That we have to rule out first, and then you label for this thyroid dysfunction.
Right, ma'am.
So it can be a condition of transient hyperthyroidism.
Right, ma'am.
Yeah, it may be
Can I
GTD
just come in?
also.
Can I come in? Yeah.
Yes, ma'am, please.
HCG has a thyroid receptor stimulating effect, and because of that, there is always decrease in the TSH, increase in the T4 levels, and that is the reason you have transient hyperthyroidism in the first trimester whenever HCG levels are little high, and this subsides on its own after 12 weeks of
12 weeks.
gestation when
Yes.
HCG levels go down and TSH level comes up. So this is just a transient, so you just have to treat the patient.
But
for
the
the
free T4
symptoms
levels are
you have
raised,
it.
ma'am.
You don't have to treat for hyperthyroidism. You just wait and watch and keep a watch, and automatically it will just come down. So this is just a transient or gestation.
That to differentiate between gestational hyperthyroidism and Graves' disease is very important.
Yeah.
So I think the TSH
So I'll
receptor
diagnose as hyperthyroidism,
antibody
GTD or
positive, it
Graves.
goes in favor of Graves' disease. Okay, and then we have to treat the patient.
No, I would like
May
to
I
say
add
that
something?
one minute. Can I say that because that this question? See, sometimes if suppose we have a subclinical, a subclinical condition of a thyroid dysfunction, and suppose if we go only for the first trimester going into the alteration of the TSH levels, and if we miss the clinical scenario, then in a first trimester, what they say is thyroid normalcy is very, very important for the neurodevelopment of the fetus. So first come to the diagnosis and then give a benefit of either it could be a transit thing or
Right,
you
ma'am.
have
Very right.
Very right.
May I add
It's
something?
important to differentiate between gestational
We
and
have
Graves.
to exclude other conditions of hyperemesis with
Yes,
gravidarum also,
Right.
like
Yeah,
the liver functions and other. And second thing, hyperthyroidism treatment is more dangerous than alone hyperthyroidism.
Right.
If it is if it is within the range, then it is no problem. Just to keep a watch. If you are in suspicion, you can go for the TRAB antibody test to differentiate between Graves' disease and gestational hyperthyroidism. Because the drugs for treatment of hyperthyroidism is more dangerous for the fetus than
the hypothyroidism. Definitely.
hyperthyroidism itself.
Yes. Thank you so
And
much.
at 24
next
weeks,
question.
we'll monitor for the goiter and the streamer length.
Ma'am, we'll come to the
and
management
fetal heart.
part. Can we pose the next question to Dr. Manoj now?
Can we request please speak one by one? There was a little bit noise.
Dr. Manoj, sir, could you please tell us how would you proceed with managing this woman?
Yeah,
We know her
basically
TSH.
these patients respond to propyl thiouracil and in second and third trimester carbimazole, and we'll monitor 24 weeks of fetal for goiter and femur length, and fetal heart it should be less than 160 and femur length should not be short. And as previously said that we'll do TRAP, that is TSH receptor antibody monitoring, and if it increases in first and second and third trimester, then we'll see for fetal goiter and heart rate.
Now, coming to what Dr. Dalvi was saying initially, this is what we would talk about transient hyperthyroidism, usually needing no treatment. And treatment would be symptomatic mainly. Anti-thyroid drugs are not warranted since serum T4 levels would usually return to normalcy by 14 to 18 weeks, as you had earlier mentioned also. And obstetric outcomes is not improved in women treated with anti-thyroid drugs for gestational hyperthyroidism. This has also been proven by a lot of randomized controlled trials. So Graves' disease is which needs a treatment. And poor control, we all know, we have more increased chances of miscarriages, preeclampsia, maternal thyroid storm, and congestive cardiac failure. So, like Sir has very rightly pointed out, the drugs used in hyperthyroidism, PTU and carbamazole. For symptomatic relief, beta blockers may be prescribed for propranolol can be given, but we need to withdraw them early because they have an increased incidence of IUGR, fetal bradycardia, and hypoglycemia. Now, TSHR antibodies have been sent. Other treatment, I think Sir has very rightly mentioned how to monitor these women. Now,
monitor these women.
So, like he said, he has already mentioned all these points. This was posted as a question, but he's already answered the questions very well. So, my next question is postpartum. How do you manage these women? And I would like to, Dr. Sujata, if you could please answer, ma'am.
Yeah, postpartum patients have to be monitored when they are lactating basically, and you need to continue with your methimazole, which can be given as such. Even PTU is quite safe even in the during lactational period. And post delivery, immediately you can check the T3, T4, TSH levels, but then even after 4 to 6 weeks, you keep on monitoring the patient, because sometimes they do have relapse of the same thing. So that's why you just have to continue, and both drugs are quite safe during in the postpartum period during lactation.
Can I add postpartum this thing? Like postpartum, suppose it depends whether the patient is in methimazole or a PTU. So if suppose a patient was taking a methimazole and the dose was less than 5 to 10 milligrams per day, or if she was in propylthiouracil and the dose was less than 100 to 200 milligrams, so we can stop that and we monitor every 1 to 2 weekly that patient. And simultaneously we can get the thyroid receptor antibody, that is TRAB also, and usually TRAB should be undetectable. It should not be detectable. But if the suppose TRAB is high, then we should suspect that patient is having a Graves or autoimmune. In that case, then I think we should do the treatment.
But that you have to.
We have to repeat again at I think 18 to 22 weeks.
Right. Thank you so much, ma'am.
6 weeks.
And when patient is on PTU, LFT needs to be monitored, every 6 weeks.
And the target,
hepatotoxic. It is
exactly. And the target, when we are giving these drugs, we should have a free T4 target and TSH target during pregnancy. So the target for T4 is 2 to 2.5 is the target, and for TSH it is 0.1 to 0.4. That is the target during pregnancy.
But even they says in a Graves disease, because we are getting as a last referral center, so we are treating most of this Graves disease and with pregnancy. So every case has to be individualized. In many cases, we have to use even for the beta blockers also. Depends upon how much is the she has a tachycardia or patient will have a tremor and a clinical manifestation.
Exactly. Beta blockers is for that symptoms, and during pregnancy should be avoided ideally until she has a severe symptoms.
So in a moderate
effect on the fetus.
No, but in a moderate to severe cases of the hyperthyroidism, then after 4 to 6 weeks of the postpartum period, again you have to evaluate it, and then accordingly you have to treat it, because treating a hypothyroidism is quite easy than controlling the thyroid functions at a hyperthyroidism at postpartum itself. It takes a little time to get settled at the postpartum period.
So like Dr. Rajshri rightly said, we need to individualize each patient and take each patient as they come. So every patient cannot be we cannot treat them in a blanket way. So Dr. Tarini, would you like to take the next case, please? Ma'am, yes. Tarini ma'am.
So the next case, everybody is bubbling in the knowledge because of the thyroid problem. So I think it's like a pandemic of corona. So another, I present a 23 years female with a spontaneous conception, but like investigation her TSH level 11.4 and free T4 0.9. So first of all, I would like to ask Dr. Rajshri, what is your diagnosis? The first question to you.
Yeah, high TSH levels, young patient with spontaneous conception. TSH levels goes more than 10, then we should consider even during pregnancy to go for the complete assay of FT3, FT4, TSH levels, and if she has any autoimmune disorders, then go for a TPO antibodies. And according to that, if suppose free T4 level, T3 level is a less, and then you should go ahead with the hypothyroidism. And suppose FT3, FT4 is normal and T3, T4 level is less, then you should look for any subclinical hypothyroidism is there or not. Here at this level, to go for a overt or the subclinical, you have to decide. But as a American Endocrinological Society and the Gynecological Society, they say for a 10 is a cutoff line where they would like to investigate for the TPO antibodies also, and they would like to go for the this thing for the FT3, FT4. And though there is a subclinical thyroiditis also there, hypothyroidism, if she is in a first trimester, I would like to correct the thyroid levels, because for the first 3 months, the thyroid levels has to be in a normalcy for the neurodevelopment of the fetus. This is how I would like to go ahead.
So definitely you have also covered the risk of the due to the hypothyroidism. Anything else you want to add, Dr. Richa?
Yes, I would like to add, since this patient, she has a TSH is more than 10, that is 11, and her free T4 is normal. It is 0.9, which is in the normal category. So we consider as a overt hypothyroidism. Any level above 10 is overt hypothyroidism, irrespective of T4 levels. So this is the thing. And regarding the treatment, then one has to work up, and then we'll start with the levothyroxine. And we'll start with 1 to 2 micrograms, or we can start with 100 micrograms daily, and then we monitor her TSH.
0.62 micrograms per kg.
Well, according to Government of India, the guidelines are there that they have given depending upon the TSH value, how we monitor. Like if the TSH depending upon first trimester is less than 2.5 or 3, then suppose if any patient is having, she started on suppose 75 micrograms she is started. And if you do the TSH after 4 weeks, ideally we should monitor with TSH after 4 to 6 weeks. So repeat, TSH says her TSH is high. So we increase by 25 milligrams. So there's a beautiful table.
25 milligram, 25
micrograms.
Yes.
Microgram.
Very
See,
right.
can I talk?
Yeah.
Yeah. See, basically, she stands as a hypothyroidism in early pregnancy, but you have to ask the history whether she was hypothyroid even before pregnancy. In case she is hypothyroid even before pregnancy, what was the thyroxine that she was taking? And depending on that, depending on the TSH values that you're getting now and your free T3, T4 levels, given as a 1.2 started.
In the first
One has to understand that in pregnancy, the requirement of thyroxine is going to be more.
25
So that, as
micrograms
Rajeshri
more
ma'am
than
has,
the normal.
yes, more than what was there in the pre-pregnant level.
Correct.
And I would like to add there may be luteal phase defect also. So I would like to add progesterone also along supplementation.
Agreed, Dr. Manoj.
Agreed.
Valid point. Very valid point.
She's unlikely to have a hypothyroid before unless she has stopped the medication totally, because it is unlikely to have a TSH level of 11 if somebody is already known a hypothyroid.
Yeah.
Unless she has stopped the medication and not investigated herself. But generally people are quite dissing about the whole thing. So generally they will not have a TSH level of 11 if they already known hypothyroidism as such. This may be for the first time that she could have been detected as such.
Yeah, could be.
My opinion is my
possibility of
Dr.
subclinical
Jaiswal,
going into the
Dr. Jaiswal, I want your expert comment.
I feel like the patient is hypothyroidism, she should be treated properly and early also, because this is a time of neurodevelopment. We cannot delay it. So we should control the thyroid level as early as possible. And we know the cut limit also on the first trimester, second trimester, and third trimester. So we have to maintain that level.
Dr. Jaiswal, what is your opinion to treat the subclinical hypothyroidism?
In the subclinical also, if the patient is required, we have to add. Doesn't mean it's 25 microgram or 75 microgram, depends upon how much the level, and it should be given. Because here we know that this can cause problem in the neural development.
Yeah, myelation and neurodevelopment. So it should be treated, even I think so. And
I think we all safely say we should be liberal while treating subclinical hypothyroidism, and we take it with a pinch of salt. Right. So now coming to the next case, we have 32 years Primi. Her pregnancy test is recently positive. Her TSH values are 4.2. So how would you manage? Dr. Vinita has been quiet for quite some time. So Dr. Vinita, would you like to please take this question?
Yes, as the age is on the advancing side, like 32 years old, the pregnancy is precious for her. So we will investigate this patient fully. Only TSH level is here. We have to find out the FT4 level also. And if we are in the doubt, then we can go for the antibody test also, TPO antibody. And if TPO antibody is positive, we can add thyroxine to save the pregnancy. But because the level is just 4.2 and there is no any history of miscarriages or anything else,
A lot of times when Dr. Vinita, the patient says, "Madam, ये तो normal के उस range में दिखा रहा है." What they come with the lab values that they say कि "Madam, ये तो normal है, आपकी medicine शुरू कर रहे हैं." So what values? What values do you apply?
The normal value is 2.5. So we have to say about the normal value is 2.5. You are in the doubtful range. 2.5 to 4 is a doubtful range, and your age is on advancing side. So we have to go for the antibody test. If it is positive, we should start the at least 50 microgram of thyroxine to that.
So would you routinely recommend an anti-TPO antibody test for all women
No,
who come
ma'am,
with the
no,
borderline TSH
No,
levels?
no, ma'am. Practically, I'm not routinely advocating for anti-TPO antibody. In those patients who are having the history of miscarriages and having the normal TSH values, here I go for the TPO antibody and I find out the TPO antibody positive. I had given the treatment and the pregnancy is full
Conceived,
time.
yeah.
Yes.
Right. Thank you so much.
Ma'am, the problem is not conception. The problem is
Continuation of pregnancy.
Very rightly said.
Can I
even
say,
they
Dr.
say
Ritu? Yeah. Anything
persistent-
more than 4, irrespective of antibody result, you have to treat. Anything
You have to
between
initiate
2.5 and 4, you are in a dilemma. Get the TPO antibodies done and then treat the patient. But in any case, I would treat the patient and bring it down to at least 2.5.
I think we all agree. We do treat the patient. Or anything above 2.5, we do tend to initiate L-thyroxine.
Yes, unless antibodies are there. That's right.
Right. So, Dr. Tarini ma'am, next case, please.
So now the patient 35 years female, she's a known hypothyroid on regular treatment. She's already taking thyroxine 50 microgram and there is a history of infertility and now she is conceived spontaneously. So how would you proceed? What the complication do you anticipate? So my question to Dr. Manoj.
Yeah, ma'am.
Dr. Manoj,
So, ma'am, we'll do the frequent monitoring of TSH for to the target level of pregnancy. So that will be in first trimester 2.5, second trimester 3, and third trimester 3. And we will anticipate the chances of miscarriage. So we'll try to be more careful in this case.
So would you like to any modification in the dose? Suppose she was taking suppose she is taking 50 microgram. So would you like to, add some more levothyroxine in this first trimester?
Yes. Add it more of 25.
Yes.
And with the
And what will
progesterone,
be-
because she is 35-year-old and infertility conception. So what I would like to go for this optimal good level of the thyroxine and also giving a supplementary progesterone, what rightly sir only told for the LPDs.
Yeah.
These two things are very important, and they says every 4 weeks you go for a level of the T3, T4, TSH and to titrate. And in the second trimester, it's okay. A little bit fluctuation, it may not cause any problem. But suppose infertility conception and they have this thyroid dysfunction in a first trimester, that crucial. It has to be monitored for the baby's development. That is how the guidelines are given, and we agree. We practice those things only now.
So here 2 points very important, adding the more levothyroxine and follow up the 4 weeks interval is very important.
Yes.
Dr. Jaswal, would you like to give your expert comment? Dr. Jaswal?
I think Dr. Tarini, they have already added it, and definitely we have written here, we have to increase the dose because our aim is to control as quick as possible. We can't wait because the patient is in the pregnancy condition and we know the normal level also. So have to bring it down.
She is elderly primary gravida.
So she can go into missed abortion anytime.
Continuation of pregnancy is very important, and the development of the brain of the female.
Is because at the end we should not give baby to the
baby. Yeah. So
definitely will add.
So how to manage women with hypothyroidism primary pre-existing postpartum period?
The postpartum period, once the placenta, Bharti madam is telling later.
Dr. Bharti, you are.
Let madam, we are making time on this platform. Thanks
Dr.
to
Bharti. Dr. Bharti is there?
Yeah. She raised
Dr. Bharti, आप mute पे हैं मैम. मैम आप mute पे.
Please unmute yourself.
Yeah. Sorry about that.
Yeah, please.
Thank you. See, here she is already a patient of hyperthyroidism primary, and now she's in a postpartum period. So most important is, you have to monitor her by doing her TSH levels, because the requirement is going to definitely go down and it will not be the same as that in pregnancy. And more important is that you have to monitor her thyroid functions, and depending on the levels, you're going to taper the doses or you're going to stop it. But at least 6 weeks she has to be on the L-thyroxine, especially so because if she's breastfeeding. Secondly, after 6 weeks, you check the TSH levels, check the free T3, T4, and then depending on that, you might stop also her L-thyroxine. But most important is you have to keep a watch that she doesn't fall in postpartum thyroiditis, which could be autoimmune,
Right.
So strict monitoring and slowly decreasing the doses, that should be the main care in the postpartum management.
Right. Thank you, ma'am.
Tapering of the doses is needed much more, rather than
we
withdrawing.
usually reduce the dose to the preconception level.
And then you can gradually stop it.
Monitor, titrate. Right.
Yeah.
Thank you, ma'am. So we come to our last case, and Madam very rightly brought up a very pertinent point following women who are previously hyperthyroid. So we have a 34-year-old para 2 live issues, delivered 4 months back. She presents with irritability, weight loss, palpitations. She was on thyroxine during pregnancy, which was stopped in the postpartum period. Relatives are complaining that she's been moody and they're blaming it on delivery. They feel that's more of postpartum blues and postpartum depression. So what would be your diagnosis in this woman? Your investigations would you like to do? So I would like to, Dr. Rajshri, would you like to take the question, please? Regarding the diagnosis. Bharti ma'am would like to answer.
Yeah, see, she's delivered 4 months back, gives history of irritability, weight loss, palpitations, and she was on thyroxine during pregnancy, but she stopped it at postpartum, I think, right? That is what is the sentence. So she could be a case of, as I mentioned in my last talk, the last statement that I made, that she could be postpartum thyroiditis, which could be an autoimmune disease where there is a destruction of the thyroid follicles. And because of that, initially the T3, T4 levels increase and there's a state of hyperparathyroidism. And because of that, she'll have tachycardia palpitations, and she'll have sweatings, and maybe, she's intolerant to cold. And you have to see that she doesn't go in postpartum depression, because there could be a chance of this woman to go in postpartum depression also. So you have to again see her thyroid functions in detail, TSH, T3, T3, T4, and you see where she stands, because this sort of a thyroiditis, initially it could be a hyperparathyroidism, and then after a few weeks, once the thyroglobulin has been exhausted, then the same woman, we will see that they go in the phase of hypothyroidism. So monitoring of all the thyroid functions, and depending on that, you will manage her. And clinically, if she's in palpitations with atrial fibrillation, maybe you will add propranolol also in this, and maybe she might be hospitalization in ICU. ICU with our ICU friends helping us.
Yes, Dalvi ma'am.
There can be precipitation of grace. There may be precipitation of grace, and we'll do free T3, T4, TSH and trap, and she may require beta blocker and NSAIDs. And in grace, if there's a grace, then anti-thyroid medication may also be required.
I would like to say only one thing is that when the patient is on the thyroid treatment, so don't withdraw immediately. I think this is the message. It has to taper down, monitor with the doses of that, and then it should go in a control and exclude the diagnosis of postpartum thyroiditis also. And with that, what rightly Dr. Bharti madam said is that the first initial phases of the hyperthyroidism, where the patient will become irritable, or in a depression or palpitation, tachycardia, that phase makes the patient more worrisome. So their symptomatic treatment will help the patient, and after that, then again we should switch over to the thyroid, whether she is in a hypothyroid state or she is coming to the euthyroid state. So I think you have to it is a very crucial thing in a postpartum cases to taper and monitor and treat the thyroid dysfunctions.
Yes,
it is first phase of hyper followed by hypo. And most of the symptoms are, they don't take it as hyper and hypo, they are being taken as anxiety, neurosis, things like that, or maybe postpartum depression. So you should not mistaken them with that. Just get a thyroid function test done and treat them accordingly, and monitor these patients for almost a year, because they become euthyroid almost after about a year of the post delivery. So you have to monitor this patient every 4 weekly, 6 weekly, whatever it is, till at least 1 year in the postpartum phase, and you'll be able to tide over the crisis of postpartum thyroiditis.
And also we need to remember that 10 to 20% of them will become permanently hypothyroid.
Hypothyroid.
Also.
That is.
And a yearly TSH also in these women. Following after the completion of the whole course, she needs to keep a watch on her TSH so that she doesn't end up becoming hypothyroid.
One thing is that we have all missed is that we should do a thyroid sonography to see how much is the fibrotic activity is there, or the size of the thyroid gland, that we have missed in that. But in the postpartum thyroiditis, postpartum thyroiditis, any fibrotic things they have there, or the replacement of the thyroid cells with the fibrosis, that is also very important to look for that.
Right.
Ultrasonography of the thyroid or the leg gland.
Tarini, madam?
Which women are more risk?
Yes.
What is
so, Maida, I really want to know which women are more at risk for PPT, because this is a very, fatal condition.
Or thyroiditis.
Patient develop the psychosis.
Autoimmune disorder before, or family history of autoimmune thyroid disease.
Also, women who have high TPO antibody positive, also, they are also at risk of PPT.
Yes.
And it's mentioned here type 1 diabetes and SLE, patients who have got autoimmune disorders. So these people are very prone to have postpartum thyroiditis.
Right.
Dr. Binita, would you like to add something? Dr. Binita Avasti?
Yes, ma'am.
Yes.
I would like to add something, because the proper follow-up is very important even after the delivery, because most of the time patients are not taking their drugs. And you should also know very clearly that initially patient may be hyperthyroidism, then it may become euthyroid, then it become hypothyroidism. क्योंकि patient कई बार ये कहते हैं कि मेरी दवा जो है वो गलत चल गई, अब तो मुझे कोई problem नहीं है.
मैंने बंद कर दी.
Yes, at least हमको तो क्लियर पता होना चाहिए कि नहीं तुम्हारी दवाई बिल्कुल ठीक चली है, पहले ये प्रॉब्लम थी, अब ये है, और अब आगे ये हो सकती है. तो हमें पेशेंट को भी बहुत क्लियरली उसकी काउंसलिंग जरूर करनी चाहिए, क्योंकि आई हैड सीन सो मेनी टाइम पेशेंट्स रिपोर्ट लेके आते, कहते मेरे को नहीं था थायराइड, देखिए अब रिपोर्ट बिल्कुल नॉर्मल है, मेरी मेडिसिन चलाई. तो वी शुड ऑल्सो वेरी क्लियर अबाउट दिस एंटिटी postpartum thyroiditis, which is not very common. Even we are not very interested, because till delivery we are taking so much care of thyroid function. After delivery, even patient and clinician both are not very keen to see the thyroid function. So we should also very clear about this entity.
And they stop following up with us, no? Then after 6 weeks, they say,
yes, ma'am. They stop following us, but they are not stop blaming us.
Yeah, they start taking care of the neonate. So they get busy in that.
Yes, yes.
So now there's very monitoring is very important. Follow up.
So when you are discharging any patient with hypothyroidism, even hyperthyroidism, you should say very clearly that you need a proper follow up, and your function will be assessed after 6 weeks. So when we can say then your drug will be continued or not, or drug doses will be reduced, or whatever be done.
Also for the recurrence is also not very common, but it is there.
Yes,
so we have to strictly tell them to follow up.
Yes,
because once they go in the peripheral psychosis, that is a very bad.
Ma'am, this type of patient are very unstable. I have seen one patient that was hyperthyroidism. That patient was having increased T4 and less TSH in first pregnancy, and again second pregnancy hypothyroidism. Then again she gone in a hyperthyroidism. So we cannot say कि ये patient, especially जो hyper हैं, उनका बहुत unstable है.
Individualized
approach conditions, monitor the thyroid levels and treat accordingly.
Yes.
And give a chance the symptoms also.
And counseling is very important. You have to explain all the things to patients.
So counseling, monitoring, follow up, very, very important.
Very important.
So now the question comes, so should be screened universally to all the antenatal patients, or whom to screen, the preconception screening, what are the recommendations? So Dr. Bharti is there. Dr. Bharti, would you like to take this question?
Yeah, see, at the end of it, what I would suggest is you should at least do the screening for all, because at the first, when she comes for the consulting for the first time, and you offering an antenatal profile as investigations. I think TSH should be added as a universal investigation because it is not that very expensive and it is a treatable cause like hypothyroidism if treated in time. All those complications of the neonate and the fetus, all those cognitive impairment and your neural development is not proper. So I would advise it as a universal testing for all. And preconception screening, yes, definitely it should be done. Especially, nowadays there are elderly primaries coming. There are girls getting married at the age of 30 and going for pregnancy at 32. So I think preconception testing also should be done. And of course, all the more if there's a history of miscarriages or infertility or preterm delivery has been done or residing in areas of iodine deficiency, definitely it should be done, especially if she has a family history of thyroid dysfunction or a past history of thyroid dysfunction. So I would advise universal screening for all.
Ma'am, may I add something?
Endocrine Society says there's insufficient evidence to support a recommendation for screening. And the women who are at higher risk for developing postpartum thyroiditis, example like antithyroid peroxidase, antibody positive, type 1 diabetes, or previous episode of postpartum thyroiditis, those females should be screened.
I beg to differ.
But Indian Thyroid Society has come up with their recommendations. But I think we would stick to our society recommendations rather than the Western literature because most of the Western do not recommend universal
And
screening.
I want to add something. Screening for thyroid dysfunction is very important just to
Yes.
rule out the cause of the anemia also, which is very common in Indian scenario.
Agreed,
Sometimes we
agreed.
find that the patient is hemoglobin on lower side, then we screen for thyroid function. Then we find the cause of the anemia was in the TSH. So
Agreed.
practically TSH should be done in all patients.
Yes, I think what we do practically, I think all of us would agree that all of us do screen women who come to us and we do advise a TSH, whether she's a woman who's infertile or she's coming pregnancy for the first time.
Bharti rightly said it's not a very expensive test, so why not to offer, because it affects the fetus development, brain development also, and also in the very crucial in the case of infertile patient. So it's not very expensive. So I believe it should be given to each and every.
And I think in a government of India also now, just because I read something, in last of this thing, they were thinking of this even thyroid testing to be done with the antenatal screening at the university.
Yes, ma'am.
It's very important.
There has been things.
There has been effect.
Even in the American Thyroid Society of 2017 recommend the patient who is prone to or there is circumstances should be screened. So there is no problem. We should not read.
It's a very
there is a more common.
Yeah,
so
very
we have to screen universally.
Easy test and very easy and cheap.
Yes, ma'am.
So such a small gland, butterfly-like, really has created the storm in the obstetric and gynecology world. So conclusion, the pregnancy acts as a stress test for the thyroid gland. Already Dr. Ritu covered. And you have hypothyroidism, the women who are iodine deficient or have thyroid reserve and postpartum thyroid pregnancy, euthyroid women with underlying Hashimoto thyroiditis. However, there is inconclusive evidence to recommend for the universal serum TSH screening at the first trimester. But at the end of panel, we all agreed that we should give the screening for TSH because it's not very expensive, but it has very fruitful effects on the fetus as well as the mother's health well-being.
So to summarize that, it has to be a proper screening for that. Give a thought for TSH. Let it get diagnosed. What sort of this thing? Go for the T3, T4, TSH levels. Treat it accordingly. Specifically, give more 25 microgram to the first trimester, and again give the same care while going down to the postpartum period. Prevent and diagnose the postpartum thyroiditis. In a Graves autoimmune, it has to be diagnosed early. Treat accordingly in that. And wonderful questions. Wonderful panel
so much,
organizer, moderators. I would like to thank to Dr. Srikhande madam. And I'm sorry I got late because I was stuck to the Doordarshan program. So I came.
Okay.
I'm so sorry for I took tea also because the whole day I didn't had lunch also.
Oh,
Thank you so much, sir, that you could make it.
Still, you can beautifully. Yeah. So it's a preventable problem. We should prevent.
So to conclude this session panel, it was a very enlightening session and various important points have been brought out by our esteemed panelists and moderators. SP Jaiswal madam, you brought as an expert, Tarini madam, Dr. Ritu madam, all your slides were wonderful and we are highly enlightened. So starting from gestational thyrotoxicosis to postpartum thyrotoxicosis, so we have clear guidelines now that we have to do routine thyroid screening in all the patients, and if it's the case of previous hypothyroid who has now conceived, then the dose of thyroxine should be increased. That's a very important point that should be brought out, and we should focus on the fetal neurodevelopment. So thyroxine replacement is very mandatory, proper counseling. And Dr. Rajshri Katke madam, she aptly brought out the point that thyroid ultrasound is very much required in postpartum thyroiditis. And though it's postpartum thyroiditis and all, many times only the physicians deal, but we also should know that the patient may move from hyperthyroidism to hypothyroidism, so which was very well brought about by this panel. So thank you panel, all the panelists, and thank you Lakshmi madam for this wonderful ISOPARP session.
Thank you so much.
Manoj
First,
sir.
I should congratulate to whole team. I should congratulate to whole team. Everybody is so expert in their field, and they have so much. Definitely, Taniji and Dr. Ritu, she has done a lot. But along with Rajshri, Sujata, and Salja and Ritu, I'm sorry because I could not see all of you on this screen. But I know even Vinita, all of them had Richa, and Dr. Manoj, all of them have added their points very well. And in nutshell, we have to investigate every patient whenever she comes, or we feel even it should come in the Indian guideline should come as a routine investigation of the thyroid. Also recommend that the patient with the high risk or the area where there's a prone should investigate. But we definitely and treat also in time to prevent loss of complication. Thank you so much to all of you.
Thank you so much, ma'am. Thank you, everybody.
Thank you, everybody. Thanks a lot, Dr. Lakshmi ma'am. It was a wonderful session. Thank you, Ruchika. Thank you,
Thank you, ma'am. Thank you.
Dr. Jaiswal, there is one question from the audience. Can you say the trimester-wise TSH levels?
Yes, madam. Definitely, it was shown on the slide. Yes. But again, I am repeating. In the first trimester, the level should be within 2.5 micromole, and then after that, it is in the second trimester and third trimester, it should go up to 3. Is the level of the cut level of the
lower limit is 0.1 in first trimester,
0.1, 0.2, the
0.1,
0.2,
0.3, and the upper value is 2.5 and then 3.3.
And that is the upper cut limit of TSH.
Lower limit is 0.1 to
2.5, 0.2 to 3, and 0.3 to 3.
Richard, after MTK committee chairperson elect, so you can answer this question on NTD. What should be the dose of NTD injection before 12 weeks and after 12 weeks of pregnancy?
Ideally we should give 50 micrograms, but the thing is ACOG says since 50 is not available, we should give 30 micrograms irrespective of period of gestation.
300. Yes. 300. And what about the dose of NTD in vesicular mole?
We give 300.
So
300 universal. 300. Except first trimester abortion, we give 300 universal to one.
International with us. So just remember, there was queries from the audience that 300 is the standard. Whenever we are saying NTD, give 300. Please give it in deltoid and see that there is no expiry and all. It is stored properly. So thank you so much, Dr. Jaiswal, Ritu, Tarini, all the panelists, chairpersons. Alka could not log in, otherwise उसने शेरो शायरी के साथ आप लोगों का शुक्रिया अदा किया रहता है. I'm very poor in all that things.
Thank you, ma'am. Thank you so much for inviting us.
Thank you, Lakshmi.
मैम तहे दिल से आपको शुक्रिया इस मौके के लिए. Thank you, मैम.
Thank you so much.
कानपुर वाली है ये बोले.
मैंने थोड़ा ऐड कर दिया शेरो शायरी. Thank you, ma'am. Thank you.
Thank you, chairperson. Thank you, Dr.
For logging. Yeah.
Lakshmi, Lakshmi.
Thank you, Lakshmi. And
Lakshmi.
Dr. Rashmi, Dr. Ruchi.
हाँ, नवी मुंबई से भी हम शुक्रिया कर रहे हैं। आपने इतना
शुक्रिया,
अच्छा
आप
पैनल।
लोगों से मुलाकात होने के लिए शुक्रिया कहिए ना, इसी
हम
बहाने।
नवी मुंबई से शुक्रिया।
अच्छा हो गया ना,
बहुत बढ़िया हुआ, बहुत बढ़िया।
Nice. Thanks a lot. Thank you.
Absolutely.
It was very interesting.
बहुत अच्छा।
Thank you.
Thank you, ma'am. Thank you.
Thank you.
Thank you.
Rajashri ma'am, bye. See you.
Dr. Richa, you.
Bye, Vinita.
Dr. Richa, you
Bharati
also got
madam.
good points.
See you,
Sujata ma'am.
Bye, Rashmi ma'am. Bye bye.
Bye. Nice to see you.
Thank you.
Everything.